Thank you. Good morning, everyone. It's a real pleasure to join you here today. I'd like to thank Dean Diaz-Rue for the invitation and Drexel University for supporting her and putting on this meeting. And I'd also like to acknowledge the honor that you're placing on public health practice by putting us in the opening panel. Thank you for my fellow commissioners, some of whom I'm getting to meet for the first time. And Joe, thanks for those important framing remarks. Let's start out by acknowledging that urban areas have unique challenges that affect the health of their residents. And with this in mind, I want to begin my presentation by sharing some of what I view as the things that make our cities unique, especially my own city, New York City, which is a densely populated vertical city. This low sprawl urban form can both support sustainable lifestyles with less encroachment on open space, habitat, watersheds, and simultaneously support healthier lives. For example, when we have robust public transit systems, as we have in New York, it encourages residents to walk, to be physically active, while also leading to less greenhouse gas emissions. And at the same time, similarly, multi-house apartment dwellings can lower per capita energy exposure while also reducing social isolation. At the same time, of course, our urban built environment has negative aspects that can also affect health, crowding, lack of green space, air and noise pollution, housing stock of varying quality and age. All of these can combine to create the challenges that we face in addressing the health of big cities in particular. In addition to the built environment, we also have the social environment that affects the quality of residents' lives. And urban areas also concentrate social isolation, violence, and extreme poverty in New York City. 1 in 5 New Yorkers lives below the wholly inadequate federal poverty line. Half of our population in one of the richest cities in the world lives at or near poverty. This slide shows where people of color live in our city. These are also our poorest neighborhoods in New York City. As in many big cities, race and income track together because that is how racism works. It is not by choice, but reflects a long history of bad policies and that are rooted in racist policies. Both institutional and interpersonal forms of racism can contribute to racial and ethnic disparities in health, both directly by affecting a woman's experience over her life course. Discrimination has an impact on her babies. Also indirectly, where residential segregation results in people of color having worse educational opportunities, worse housing conditions, less access to healthy food or safe places to exercise. This dissimilarity index, the basis of the map here, it measures the extent to which populations are distributed or maldistributed by census tract. It is a ratio, and it varies from 0 to 100, and a high value indicates that two groups tend to live in very different spatial arrangements. In New York City, the black-white dissimilarity index is over 80, over 60 is considered high. And the way to put that in simple language is that 80% or more of either group would have to move in order to get a non-disparate residential distribution across the city. By this measure, New York City is one of the 3 most racially segregated cities in the United States. And of course, this tracks with health. What's shocking to me about this slide, a slide that I show often, is not just the disparities by individual health outcomes or the level of disparity that exists among them, but the systematic clustering of poor health outcomes in the very same neighborhoods that have also the highest concentrations of poverty and are where people of color live. And this clustering alone should be evidence enough for all of us that, independent of the causal pathways involved, much larger structural factors are at play. Maps like these make injustice visible. And that is why it is my privilege as Health Commissioner for New York City to lead our department's efforts to address these structural factors that prevent New Yorkers from living and achieving the healthy lives that they both want and deserve. In some neighborhoods in New York City, I'm missing a slide, I apologize. I was going to show you a slide that shows avertable deaths. And some neighborhoods in our city, half the deaths that occur in that neighborhood wouldn't happen if we had the same mortality structure in those neighborhoods that we have in high-income neighborhoods. And of course, is this out of order? No, I apologize. Of course, when we talk about these social determinants of health, we are talking about lives. And this is an analysis that looked at the impact of residential segregation and income inequality, and it showed that the impact is on par with deaths from common causes like stroke. Oh, there's the avertable mortality slide. As I said, some neighborhoods in our city have half of the deaths would be avertable if they had the same mortality structure as the richest neighborhoods, which are figured there in green. So that is why New York City is taking a focus on neighborhoods. Every 4 years, the administration has to release a plan for growth for the city. And under the Bloomberg administration, to the idea of economic growth were added the notions of sustainability and resilience. In the OneNYC plan that was recently released by the de Blasio administration, the equity lens was added to growth, sustainability, and resilience. And we have 2 health equity targets. The first is to reduce the city's premature mortality rate by 25%, and the second to reduce infant mortality to 3.7 per 1,000 live births in a generation, that's by 2040, and dramatically decrease racial and ethnic disparities. In OneNYC, the mayor set out the vision that New York City will be, and I quote, the most sustainable big city in the world, a global leader in the fight against climate change, and in our vertical city, improve the resilience of housing and infrastructure that is so critical to public health protection and to health equity. We are on track now to reduce premature mortality by 25% by 2040. But of course, we can only do this by narrowing the gap. And this is shown clearly when we look at infant mortality. This shows in this slide the decline in infant mortality for Black as compared to white infants. This is the contrast in which we see the widest disparity by race ethnicity. And between 2000 and 2013, the infant mortality rate declined by 1/3 among infants born to white women and by 1/4 among infants born to Black women, with the result that there has been a slight uptick in the relative gap, despite the fact that there has been an overall decline. So we've identified a host of action areas broadly under the area of use of data for surveillance and research, use of policy tools, which Dr. Buford referred to. We happily announced a new policy yesterday when the Board of Health approved sodium warning labels for menus and menu boards, and neighborhood-based initiatives. And that's what I'm going to talk about today, is our neighborhood-based initiatives. When I was a deputy commissioner, I established 3 district public health offices located in the South Bronx, in East and Central Harlem, and in Central Brooklyn. You can see that there. When I came back as commissioner now a year and a half ago, we looked at the data to see if these were still the right neighborhoods to target, both because we were hopeful that we'd seen substantial health improvements and because we acknowledged the impact of gentrification in some of these neighborhoods. But we found that these continue to be the neighborhoods that have the highest rates of premature mortality, and continue to be the neighborhoods in which we should focus our most intensive areas, because we have a racially segregated city. By default, almost, focusing on neighborhoods becomes a strategy that supports health equity. But it's important how we frame this work. I don't just see going to neighborhoods that are the neediest as the way in which we frame our work. These are communities that have many assets and strengths. I really see our work as undoing injustice and recognizing that it is the unequal distribution of resources, not defective individuals who are responsible for the poor health patterns. So we've established and will continue to support the district health offices. I also discovered that the health department owns buildings throughout the city. Pictured here are buildings that were put in place actually in the LaGuardia era, following World War I. And we had allowed these to largely be neglected. Many of them were largely empty. That big building, the health department was negotiating to turn over to the police department. But now, using these as an asset that we have in communities, we hope over the next few years to open up 7 neighborhood health hubs. We will have 2 open by the end of this year, using our asset of physical space for the co-location of different services, including health services, which are also a social determinant of health, and allow us to bridge the gap that has been too long in existence between public health and primary care. My hope is that we'll co-locate artists, activists, people from various sectors. Each neighborhood hub will have a community kitchen, an urban garden. There's going to be space for new moms to gather together, and also for young entrepreneurs to explore ideas. The ultimate idea here is that the department will support residents and different organizations in working together, because the price of entry into these buildings is participating in a joint community health planning process. This is not easy work or fast work. I've told my staff that if we will continue to learn, and we are already learning as we do, and if we don't make mistakes, we're not taking enough risks. But we will be guided by a vision of public health as rooted in social justice, a belief that we can work with communities to help them be stronger, provide them with tools, supports, organizing, and together work to make communities healthier. These are some of the goals, sort of drawing on the citywide goal of reducing premature mortality. These hubs will be focusing in particular on diabetes and hypertension. It's always important to remember that the excess mortality in poor neighborhoods is not related to exotic conditions. Neighborhoods that have an excess burden of mortality have the same causes of death. People die at younger ages and at higher rates in communities that have been so historically underserved. And working together, we are putting in place programs based in these district health centers that aim to measurably improve population health, address inequalities, close service gaps, and help community planning become less fragmented and more cohesive, and thereby advance public health. The goal of improving conditions in communities is one that is shared across agencies of the city in our current administration. And I view the notion that neighborhoods are a social determinant to be one of the most promising approaches to reducing mortality and morbidity and building the gap, and narrowing the gap. I'm privileged to join a department with a very strong legacy of use of policy tools. Yesterday, the Board of Health, which has lawmaking authority, passed a rule that will put sodium icons on every menu and menu board of fast food restaurants and chains. These now will be joined by a complementary pillar of working in communities, going to the places where people are sick, and building healthier communities for everyone. Thank you very much.